Welcome back, students. As we saw in the first session, the supraclavicular approach of achieving brachial plexus block. Now the second type or second approach is interscalene or cervical approach. Now just as during the first session, I'll just talk about the site. The site at which interscalene or cervical approach has to be achieved. Patient should be in supine position, arms lateral, heads rotated to the opposite side. Then level of C6, that is 6 cervical vertebra, is obtained by palpating the cricoid cartilage. At the edge of sternocleidomastoid, a groove is felt between scalenus anterior and scalenus medius muscle. This is the site at which interscalene approach for achieving brachial plexus block, and at this particular site local anesthetic solution has to be injected. Procedure. Now the actual procedure to achieve brachial plexus block through this approach. Needle is inserted perpendicular to the skin, passing through the EJV, that is external jugular vein, into the perivascular space. As you enter the perivascular space, you get a definite click sound, so that you have to confirm that you are in the perivascular space and not in the vein itself. Inject small amount of solution over here and see that there is flow back of solution. This confirms that you are not in the vascular space but you are in the perivascular space. After careful aspiration of the solution, desired amount of solution is injected at this particular site. After injecting the solution at this site, patient is made to sit and gentle massage is given at the site of injection so as to allow proper redistribution of the drug. Now the complications, this type of approach is actually very complicated and is full of complications. The major risk involved with this type of approach is the risk of injection into the extradural space, into CSF or into vertebral artery. These are major complications because if at all you inject this particular drug into extradural space or CSF, then it might turn out to be not a brachial plexus block itself, but a epidural anesthesia or a spinal anesthesia, for which we are not prepared at this particular site. Then the other complication may be bilateral block of both cervical plexus and both brachial plexus. Because since you are achieving this particular block at the level of C6, even cervical plexus might be blocked with the help of, instead of brachial plexus, you actually block the cervical plexus, and this can be complication in itself. Now the dose, the total amount of dose that has to be injected is around 30 ml of bupivacaine solution, which is diluted to 0.375%, or ropivacaine. This may be used. Volume should be around 25 to 30 ml, not more than that, because you are just in the perivascular space, and even if you try not to inject in the vascular space, but there is high probability that some amount of drug might enter the vascular space and cause catastrophic events. Now the third type of approach is subclavian or perivascular approach. Site, again patient has to be in recumbent position with head turned to opposite side, and patient is asked to touch his knees. This type of approach actually is very cumbersome for the patient itself. In this position, that is in recumbent position with patient head turned to the opposite side and patient asked to touch his knees, interscalene groove is palpated along the lateral edge of sternocleidomastoid muscle downwards at the level of C6. This groove is palpated and moved down to feel the subclavian artery. As you feel the subclavian artery, needle is inserted through the clavicular head of sternocleidomastoid and pushed downwards till it entered the perivascular space, again with a click. This is a very risky approach. I'll just repeat it because it's very complicated and it's very difficult to understand. So again I'll talk what is the site. The subclavian approach, the site is, it should be recumbent position with head turned to opposite side and patient is asked to touch his knees. Interscalene groove is palpated along the lateral edge of sternocleidomastoid muscle downwards at the level of C6, that is at the level of cricoid cartilage. Groove is palpated and moved downwards to feel the subclavian artery. It is at this position that needle is inserted through the clavicular head of sternocleidomastoid muscle and pushed downwards till it enters the perivascular space with a click. Now, this is the site, and this is actually the direction by which local anesthetic solution has to be injected. Now, complications of this particular approach, it is very complicated approach because it's a risky approach. Additional block, this is a risky approach just because mere site of the block and mere direction with which you are going to inject this particular drug. Another complication includes additional block may be required to block intercostal, brachial and medial brachial cutaneous nerve of arm, because these particular nerves are spared through the subclavian approach. Dose around 20 to 40 ml of 0.375% of bupivacaine solution has to be injected, but you have to be very careful that you have to inject this drug only after careful aspiration and to see that there is no amount of blood or any other fluid being aspirated from the syringe. If at all you are 100% sure, then and then only you inject 20 to 40 ml of 0.375% bupivacaine solution at the site to achieve brachial plexus block through subclavian approach. The fourth and final approach is axillary approach. This is very simple and safe approach, but it has got complications and drawbacks of its own. I'll just talk in detail about the same. Axillary approach, the site is patient should be supine again, arms are abducted or arms is abducted and maybe it is flexed at the elbow joint and kept below your head, below the head of the patient. Now a wheel is raised at the highest point of axilla where arterial pulsations are felt. Now this is very simple. Whenever the patient is in supine position, his arm is abducted and kept below his head, it is very easy to palpate or to locate axillary artery, because axillary artery, as it pulsates, that there is definite movement in the axilla. It is at this point a wheel is raised and small at the pulsating artery, and this is the site where you are supposed to inject the drug. Now procedure, needle is again inserted through the wheel until a click is achieved where it shows neuromuscular sheath, that is the axillary sheath which covers the axillary artery, has been entered. There should be a definite click, careful aspiration should be there done so that you do not inject the drug inside the axillary artery, which might lead to catastrophic events on the spot. Amount of drug to be given, 20 ml of 1 to 2% of xylocaine solution is injected after careful aspiration to see that there is no backflow from the needle or no blood aspiration from the same. Bupivacaine in the dose of 1.5 mg per kg may be employed to achieve this particular block. What are the drawbacks or disadvantages? Additional block may be required to block musculocutaneous nerve at wrist joint, because this nerve is spared by axillary approach, as this nerve is being branches of this musculocutaneous nerve is being given above the level of axilla or above the level at which we block the nerve. Therefore, additional block may be required to block this musculocutaneous nerve. Normally, radial sparing or radial nerve sparing also occur during axillary block or brachial plexus block through axillary approach. Hence, some amount of additional solution to block radial nerve may be required to be given peripherally. Advantages, because it is very simple and safe, just one surface marking, that is pulsating artery, axillary artery, which is very easy to locate by naked eye and is very safe. These are the two advantages, that is only one surface marking and is very safe approach. Okay. What are the drawbacks? Shoulder surgery could not be performed because for obvious reasons, because you are blocking the nerve below the shoulder. So whenever, if at all you want to perform shoulder surgeries, you cannot use this particular block or this particular approach for brachial plexus block, because obviously the shoulder which is supplied by other nerves are spared. Then the radial sparing sometimes occur and it is very difficult in obese patients. Say for example, if patient is around 100-120 kgs and if you want to block the brachial plexus through axillary approach, though axillary artery may be pulsating, but if a patient is that fat or that heavy, that obese, you may not be able to palpate axillary artery in the axilla. So if the site, just because it's only one surface marking, if you cannot locate the site, it is very difficult to inject the drug at that particular site and it is very difficult to achieve the block in obese patient through axillary approach. So in obese patients, rather than employing axillary approach, it is better to achieve the block through other approaches. So this concludes the brachial plexus block. I talked in detail about brachial plexus, all the 4 approaches, how to achieve the block, the drugs used for the block, complications of each and every approach, drawbacks of each and every approach. At the end of it, I can only say that axillary approach is the safest approach, with its drawback that some of the nerves are spared, and supraclavicular approach is the approach where complete brachial plexus block can be achieved, but it has got its own sets of complications. But still, by this way or that way, brachial plexus block is a major and important block which can be given to patients if at all any surgical procedure has to be done on upper limbs. Any orthopedic procedure, surgical procedures, any sort of procedure, with the help of this brachial plexus block, we achieve the main aim of our main and major importance of giving this particular block is the drawbacks of general anesthesia, which can be the complications of general anesthesia, could be avoided when you employ this type of block, that is brachial plexus block, and upper limb surgeries can be done without giving general anesthesia. Patient is fully awake, only his upper limb is anesthetized. And this type of block, if at all, and is readily employed throughout. In my clinical practice in last 10 years, I have given n number of axillary blocks and supraclavicular blocks with 100% result. Patient is cooperative, awake and happy. As soon as surgery is over, patient is able to walk back to his bed. So this is a very important form of anesthesia. I again request all of you to go through the slides again and go through it so as to master the art of brachial plexus block. Now coming back to other form of anesthesia, that is IVRA or intravenous regional anesthesia. That is very fascinating type of anesthesia because, as you all know, as all the students know, local anesthetic solutions, be it xylocaine, bupivacaine, you cannot inject the drug intravenously because as soon as you do that, you are causing cardiac arrest or it has got its own complications. So the main local solutions like xylocaine or bupivacaine, it has been labeled on the vials that you cannot do it, you cannot give it intravenously. But in this form of anesthesia, that is intravenous regional anesthesia, we inject the drug intravenously. How we do it, I'm just going to let you know. Now talking about intravenous regional anesthesia, it was introduced by Bayer in the year 1908. Local anesthetic solutions can be used IV in following cases. Now, just as I said, local anesthetic solutions cannot be used IV, but it has been proven in clinical practice that they can be given intravenously in some of the following cases, like treatment of cardiac arrhythmias. Whenever cardiac arrhythmias, dysarrhythmias occur, after giving all sorts of cardiac antiarrhythmic drugs, even then, if patient is unable or if the arrhythmias are been unable to control, then the last and final resort is to give IV xylocaine solution. This is achieved so that the arrhythmias which are non-responding to any of the treatment, commercially available or medically available treatments, the last and final resort is to give IV local anesthesia, IV local agents through the vein to treat cardiac arrhythmias. Also, it can also be used to provide local anesthesia. Now, again, I'll talk about IVRA, the technique. How do you achieve this IV regional anesthesia? The technique is, first, as you can see in the slide, cannula is inserted in the dorsum of the hand and properly secured. Say, for example, if you want to anesthetize this left upper limb, one small IV cannula is inserted in the dorsum of the arm. It is properly fixed and secured. Then another vein is cannulated in the hand. First the upper limb is drained of the blood by raising the hand for 5 minutes. Completely all the peripheral blood in the peripheral veins is drained off by raising the hand for around 5 minutes. Ishmael bandage is applied for this purpose. To achieve this, that is to drain off the blood from the upper limb, Ishmael bandage, tight bandage is applied to whole of the upper limb so that the vein, all the peripheral veins of upper limb is drained of blood. Now, 2 narrow cuffs like BP cuffs are placed on the upper limb. upper cuff is inflated above the systolic pressure. That is, if systolic blood pressure of patient is around 120 or 130 millimeter of mercury, the upper cuff is inflated around 20 to 30 millimeter of mercury more than the systolic pressure. Then once you raise the upper cuff by around 20 to 30 millimeter of mercury, you remove the Ishmael bandage which you have applied to drain off the blood. Now inject the local anesthetic solution through the IV cannula and wait for 10 minutes. After you remove the Ishmael bandage, the vein which you have been cannulated, which you cannulated before, through that vein you inject local anesthetic solution and wait for 10 minutes. This upper cuff, which has been inflated 20 to 30 millimeter mercury above the systolic blood pressure, has to be kept inflated. Now lower cuff, which is again applied, is now inflated again 20 to 30 millimeter of mercury above the systolic pressure. As you inflate the lower cuff, upper cuff is gradually deflated. Now as the 10 minutes pass, local anesthetic solution fills in the veins of the upper limb, and patient has whole of upper limb anesthetized and is ready for operation. Analgesia and motor weakness remain while tourniquet remain inflated. Therefore, once the local anesthetic solution is injected through the cannula, after 10 minutes, whole of upper limb has been anesthetized and it remains analgesia and motor weakness remain till the tourniquet is inflated. And amount of dose like 30 to 40 ml of xylocaine solution, 0.5%, or procaine 3 to 4 milligram per kg is very effective to achieve IV regional anesthesia. Talking about IV regional anesthesia procedure, it is a bit cumbersome, bit complicated, but very easy and very fascinating. When this type of block is achieved, the amount of satisfaction which you get is tremendous, because without pricking the patient, just with one IV cannula, you can anesthetize the whole of upper limb. I am just going to repeat the same again for you. Now the technique: one cannula is inserted in the dorsum of the hand, that is properly secured. Another vein is cannulated in other hand, just in case of emergency. Now the limbs are drained of the blood by raising the limb for around 5 minutes. Ishmael bandage could be used for this purpose. Then two narrow cuffs, that is BP cuffs, are placed on the upper arm. First upper cuff is raised by around 20 to 30 millimeter of mercury above the systolic blood pressure of the patient. Ishmael bandage is gradually reduced. Once the Ishmael bandage is reduced, IV solution, IV local anesthesia is given through the vein cannulated from the dorsum of the hand. Wait for 10 minutes. As after 10 minutes, as limb gets anesthetized, lower cuff is inflated again 20 to 30 millimeter of mercury above the systolic blood pressure of the patient, and as you inflate the lower cuff, you gradually deflate the upper cuff. After 10 minutes, patient has whole of upper limb anesthetized and patient is ready for operation. Analgesia and motor weakness remain as soon as till the tourniquet remains inflated, that is the lower cuff which you have inflated remains inflated. The duration of action is around 30 to 40 minutes and dose amount of local anesthetic solution is around 30 to 40 ml of xylocaine solution, 0.5%, or procaine, that is 3 to 5 milligram per kg. This is effective to achieve IV regional anesthesia. Now again, just as I said, cuff inflation or cuff deflation, it is better done in stages, because as you inflate the lower cuff, you start deflating the upper cuff, but it has to be done in stages. 30% of drug which you inject is released fast, while another 50% remains for around 30 minutes. Cuff is deflated slowly after about 45 to 50 minutes, keeping an eye on the toxic signs. The lower cuff, which remains inflated, has to be deflated only after 40 to 50 minutes, because the duration of action of local anesthetic solution which you have injected is around 40 to 50 minutes. So as you deflate the lower cuff, as you deflate the cuff only after 45 to 50 minutes, you keep an eye on the toxic signs, because if at all drug which is gradually released, because as I said earlier, 30% of drug is released fast in the body or is made available in the body in the 35%, and the rest of the 50% is released gradually. So if this 50% of drug is gradually reduced, and if you deflate the cuff, lower cuff, quite early, it is very probable that this 50% of solution which is gradually released can get an access to IV intravascular space of other parts of body, and it can easily pass or reach the heart, causing toxic complication. So always, while deflating the cuff, you should always keep on toxic signs. What are the toxic signs? Drowsiness, twitches, convulsions, hypotension, and bradycardia. These are the toxic signs which you can say. Whenever these toxic signs are present, that is drowsiness, twitches, convulsions, hypotension, you think that this particular local anesthetic solution has got an access to the intravascular space and has reached the heart. How do you treat that? If toxic signs are present, or if you see one of the toxic signs, say drowsiness or twitches or convulsions or hypotension, first and foremost thing that you are supposed to do is reinflate the cuff. Reinflate the cuff and treat whatever small complications are bound to happen, or you are seeing, say drowsiness is there or twitches are there. Treat that particular complication individually. But first and foremost thing you are supposed to do is reinflate the cuff as soon as these complications are seen. Now, contraindications for IV regional anesthesia is Raynaud's disease, sickle cell anemia, for obvious reasons, because when you put Ishmael bandage, decreasing the oxygen concentration of the blood, and hence sickling can occur. So sickle cell anemia is a major contraindication. Raynaud's disease is one of the major contraindication. Scleroderma, because of the skin infections, and due to toxicity of bupivacaine, has to be avoided. Hence, following contraindications you should consider following contraindications for IV regional anesthesia, that is Raynaud's disease, sickle cell anemia, and scleroderma. Uses: complete analgesia of the limb can be achieved, that is upper limb can be achieved. Short upper limb procedures, be it surgical procedures or orthopedic procedures, can be taken place without giving any additional drugs or any additional systemic drugs, and short upper limb procedures for around up to 30 minutes can be done without any complication. So this is IV regional anesthesia. It's very fascinating, very easy, very simple for the patient without causing any pain to the patient. But similarly, it is important that the cuffs which you use should be proper, so that if at all there is leak in the cuff, the toxic signs which I said, like drowsiness, hypotension, numbness, convulsion, can ensue very quickly. So you have to be very alert whenever you employ this type of block, and you should be very cautious. But it is very safe alternative in upper limb surgeries as compared to general anesthesia.